Professor Rafał Jajusko, you have what is described as a treatment giving a high impact on survival in patients with early lung cancer. Now, in your section of the conference, you're talking on what is the optimal care of patients with stage 1 to 3 non-small cell lung cancer. Well, let me ask you, what is it from the radiation oncologist's point of view?
During my presentation, I will be focusing on some aspects of radiation therapy for early non-small cell lung cancer. And I will start with the description of outcomes of patients treated with stereotactic radiotherapy for early lung cancer. This is an exciting topic for many oncologists because the technique was developed in thoracic malignancies since about 2000, and now we are beginning to understand what its impact on lung cancer survival is.
Now, it looks as if it may have a big impact. It's very recent, and it gives the possibility of getting much finer margins, doesn't it?
Yes, indeed. This technology was originally developed for brain tumors, and since the time we understood that it may be used also for thoracic tumors with very small margins, high precision, and very high dose per fraction, which is simply not possible through conventional radiation oncology techniques, like, for example, conformal radiotherapy. Outcomes of patients treated with this technology have been presented during the last 3 years in larger series of patients, and we now understand that the local control is excellent, like 10% local relapse rate, which is indeed comparable to what surgeons would experience in their series of operable patients. Now, the technology is used mainly for medically inoperable lung cancer patients. That means those patients who cannot undergo surgery. However, there are also numerous attempts to compare this technology with open surgery or with any kind of surgery. Of course, whether this will indeed be used in surgical patients or not will be a matter of next generation research projects.
Let me ask you though, which patients specifically would you use stereotactic radiotherapy in? Because you've got to define the tumour very precisely, and then if you hit it hard enough, you can kill the cancer.
Yes, indeed. What matters is a very adequate staging. You have to have local disease with no regional, meaning mediastinal or hilar lymph nodes involved, and you have to have tumors that are generally not more than 5 centimeters, although there were also several series of selected patients with higher primary disease volumes.
But basically it needs to be stage 1, not stage 2 or 3.
Yes, exactly. Also, it's very important to have very well-defined staging based on PET scanning and assessment of lymph nodes by EBUS or EUS, meaning endobronchial or endoesophageal ultrasound. And any other technique that is important for staging has to be very well adapted here to make sure that we are dealing really with stage 1 non-small cell lung cancer.
Now, you said that it needs to be given to patients who are basically inoperable. Now, that gives you a dilemma, doesn't it? You have a patient, first of all, you've got to decide on whether it's resectable.
You know, for now, it's quite obvious because in most European institutions, we practice multidisciplinary care. So we meet with other physicians, thoracic surgeons, radiologists, pulmonologists, and so on, to discuss the patient. And it's quite obvious, based on performance, age, comorbidities, and so on, for most of the patients who should be treated with standard of care, which is surgery, and who may benefit from this procedure because the risks of surgical procedure is too high.
Now, how difficult is it to give stereotactic radiotherapy, though? Because you've got to have a patient who doesn't move.
Yes, the problem is that to obtain a reliable treatment plan, you have to adopt a number of quality assured procedures in your radiation therapy department. First of all, during treatment planning, you have to precisely know how the tumor moves. To achieve this point, what is called four-dimensional CT scan is essential. That means that you are able to obtain the tumor motion picture after you have your CT scans, and you account for that in your planning of radiation therapy. So once you registered how the tumor looks and how it moves during respiration, you just, as minimal margin as possible, meaning 3 to 5 millimeters, and you irradiate this to very high dose.
Is it suitable for treating all tumors? Does it matter about the location?
That's a very good point. It's for now on, it's not. For centrally located tumors, we have a problem because in series of patients that have been published, there has been some increased toxicity, including fatal toxicities. So clinical trials to answer the question how we should fractionate centrally located tumors are ongoing and are very promising.
Does this all add up to the need for a centre of excellence for doing this, or do you think this can be used in most centres?
I think that for now we have to have a very defined radiation oncology centers to start such a procedure, because it needs a very extensive quality assurance program. So I don't think that it will be cost effective to do it in every radiation oncology facility in the country. For example, in Poland, where I practice, we have about 4 to 5 centers that are doing stereotactic radiation therapy for early lung cancer, and other centers are referring patients to us. The volume of patients is not so high, so we can actually achieve this goal within a limited number of centers.
Now, in non-small cell lung cancer, you've been using it for 10 years or so.
Yes.
Long-term results are awaited, of course, but you intimated that there could be a big impact on survival. Now, I know you don't have the data yet, but how big an impact are you looking for?
You know, there has been a very nice publication from the group of Free University from Amsterdam. Actually, this group pioneered stereotactic body radiation therapy in Europe, together with colleagues from Karolinska and other institutions. And this group has very nicely shown that in their very well-defined cancer registries, implementation of stereotactic radiotherapy for early non-small cell lung cancer has impacted survival from the epidemiological perspective. I was talking to my colleague, Dr. Suresh Sanan, this morning about this important landmark paper, and he told me that they are looking for the global picture in the Netherlands to see how much it impacts on outcomes after the procedure was introduced. And it looks like it's really a huge impact.
In percentage terms then, in both quality and length of life, what might that be?
First of all, the length of life. Just the percentage of cured patients with early stage increased by something like, if I recall correctly, between 15 and 20%, which is a remarkable thing, especially in this population of patients for whom traditionally surgery was contraindicated for a number of reasons.
And therefore no cure automatically.
And we have been treating those patients with traditional radiotherapy, which has limited long-term outcome impact.
What should doctors be remembering from this?
If any physician sees an early lung cancer patient that is not suitable for surgery, for comorbidities, age, or any other reason, the patient should definitely be considered as a candidate for stereotactic radiotherapy. rather than conventional 3D radiotherapy or any other treatments.
And you did mention toxicities that are still being examined. Are there any risks?
Actually, there is a number of toxicities, but once you have the procedure well developed and you pay attention to what we know about this technology, it seems that the risk of serious toxicity is relatively limited. Certainly not more than for traditional conformal radiotherapy. The toxicities are different, and careful treatment planning is essential to achieve the measures to minimize toxicity. According to well-defined series of patients, major toxicities occur in less than 10% of patients, which is a very good outcome for such a treatment.
So what you're saying, in a nutshell, is that radiation is a powerful curative modality?
Yes.
Professor Jajusko, thank you very much indeed. That's great
Thank
to
you.
hear from you, and we look forward to hearing more about this.